right. I didn't realize when I stopped my other video that there wasn't much more to do, but I want to look at the antagonists for a minute. And we're just going to break them down into the alphas and the betas, starting with the alpha-1 antagonist. So again, when we think of alpha-1, we're thinking of really the vasculature. So the alpha-1 antagonists or the alpha-1 blockers are going to be used to bring down the blood pressure by vasodilation. So they can be used locally to vasodilate, or they can be more systemically for vasodilation. So there's a couple. This kind of gets a little complicated. So in that bit about shock you see on the slide here, so shock is a situation that's kind of confusing in that shock causes circulatory collapse. And what that means is essentially, usually what causes someone to go into shock is a lot of vasodilation. And there's lots of reasons why that can happen. It can be mediated by the central nervous system. It can be an allergic situation. It can be sort of all over the map. But when somebody is experiencing shock, they are experiencing what we refer to as circulatory collapse. So it might be a little counterintuitive to say, why would you ever want to give a vasodilator to somebody that has circulatory collapse? Because that seems to not make any sense whatsoever. And the reason for that is because when they are in this state of circulatory collapse, in a nutshell, what happens is it reverses the capillary dynamics. So normally, remember that as we move into a capillary, the pressure on the arterial end of the capillary tends to be higher. The hydrostatic forces are higher, which pushes fluid out. And then the presence of the plasma protein or the oncotic pressure pulls the fluid back in again, right? And so that's why we don't lose all of our blood or fluid out of our blood vessels every time it goes through capillary beds. But with shock, they have a situation where they have already profound vasodilation, most likely, and they have all this fluid leaking out of their vessels. And so when you vasodilate even more, the pressure in that area gets even lower. And when the pressure gets low enough, you basically are you're creating, the hydrostatic forces in reverse, if you will. So the pressure is going to be higher on the outside of the capillary than the inside, and it will push fluid back in there. I don't know if that makes sense. It's kind of complicated, but if it doesn't, you don't need to worry too much about it. You'll probably at some point in your career, if this is something that you do regularly, you'll kind of get more familiar with that. It's sort of a strange mechanism. But we would expect to be able to bring the blood pressure down with an alpha-1 antagonist, which is what we're really thinking of here. So you can see hypertension. Pheochromocytoma is kind of a weird adrenal tumor that causes them to release a whole bunch of adrenal hormones, including norepinephrine. And they can get quite profound hypertension kind of out of the blue. And that's why these are used. They're not used forever. They're used until you can kind of get the tumor under control. We're going to talk quite a bit about blood pressure medications in the cardiovascular unit. And what we will come to understand, and hopefully you will really get, is that anytime you decrease blood pressure suddenly, that's going to have some potentially serious consequences. One of which, and the alpha of all of the drugs that vasodilate, these are going to be the most profound. So these are going to profoundly decrease blood pressure suddenly. And when that happens, oftentimes the blood flow is inhibited, specifically the blood flow to the brain, especially as they're getting kind of used to this new medication. We tend to get more adapted to it over time. People tend to adapt better to it over time. But initially, their pressure is so low that they may develop what we refer to as orthostatic hypotension, which is a situation that when they go from a lying to a sitting, or a sitting to a standing, or worse, from a lying to a standing, they get very dizzy and they can potentially faint. And that's because they're not able to generate enough pressure to actually get the blood to the brain, essentially. And generally, like I said, that's more pronounced in the beginning. So they call that a first dose phenomenon, or the first few doses. They tend to acclimate to the medication over time, but you got to be aware of that. And so you wouldn't want to give these medications, an alpha-1 blocker, to, let's say, an elderly person that's brittle boned and potentially going to fall if they go from a lying to a sitting, or sitting to a standing, and they get profoundly dizzy. So that's something to sort of think about there. And also, with almost all of our antihypertensives, and the alpha-1 antagonists are no exception here, with men, this is something to know. There's oftentimes quite a bit of sexual dysfunction that accompanies the medicines for hypertension. And alpha-1 antagonists are notable for this as well, in that they cause an inability to ejaculate. And the reason for this is their smooth muscle inhibition at the vas deferens and the ejaculatory ducts. So that is something that would be good for people to know going into this. These drugs, of course, are going to compete for with norepinephrine, at the synapse, and therefore also produce or inhibit the symptoms of fight or flight. So those are the alpha-1 antagonists. The beta-1 antagonists, or the beta-blockers, these are used a lot. These are going to be something probably a lot of you have heard of beta-blockers before. Therapeutically, they're used for mostly cardiovascular situations, arrhythmias, because this will suppress the ectopic pacemaker, any out-of-place pacemaker. They seem to be especially good at slowing the ventricles down, which is good. Certain medications like cardiac glycosides, which are used for heart failure, we'll talk about those in the next unit. Those can produce an arrhythmia, and the beta blockers are good at counteracting that particular arrhythmia. They decrease the work of the heart, of course, because they're beta blockers, decreasing blood pressure, decreasing cardiac output, decreasing contractility. So if someone has angina, these drugs are used frequently to decrease the work of the heart. If people have hypertension, these are going to decrease blood pressure, not as profoundly as the alpha blockers, so they're more user-friendly, I guess, in that respect. If somebody has signs of thyrotoxicosis or Graves' disease or hyperthyroidism, and their heart's beating too fast, they have tachycardia, these drugs can be useful to kind of deal with the side effects of the disease process of this hyperthyroidism, which is an elevation in heart rate, and increase in blood pressure, and increase in body temperature, and all of that. They are used for migraines, sometimes prophylactically, not always. Migraine treatment is pretty hard to get at because migraines are sort of elusive in that we don't know often what the triggers are. But many patients actually can be helped with beta blockers if they're used prophylactically. And honestly, the mechanism is pretty unknown. Nobody really knows why they help, but they seem to help some. There was some evidence that migraine headaches are sort of vascular in nature, and maybe there's like this sort of unstable blood vessels. I honestly don't know if this is really true. They're sort of revising this currently, but up to fairly recently, we thought of them as being vascular headaches. And so that's sort of the idea around the beta blockers. Like I said, they don't help everybody, and they're only really going to help prophylactically, meaning you don't want to, when somebody has a migraine, they're not going to do much. They're more used to kind of stave off the migraine attack. Side effects, we might think of wheezing, because you're going to get some constriction of the airway. So we don't probably want to give these to people with asthma unless we have to. They make people pretty tired, and that's, again, pretty common, tired and or depressed. They may cause somebody to be nauseous and may cause some diarrhea. And the idea here is that we're blocking the sympathetic side of things, and so we're getting this sort of like overshadowing of the parasympathetic nervous system, and that's probably why that's happening there. The toxicity of beta blockers are going to be severe bronchoconstriction, really low blood pressure, potentially heart failure. You are decreasing the contractility of the heart. So that's something I kind of always wonder about with these patients. We give them to people with angina, but I wonder, like, over time, if they did this for a long time, is heart failure something that we're going to see? I don't think that really has been shown in the evidence, but in the research, pardon me, but it's something I kind of would wonder about. They may cause an AV block, and they may cause a low blood pressure in diabetics that are being treated with other medications. So that's something to sort of think about. So we probably would want to really seriously reconsider using them in asthmatics, in people that are already hypotensive, in people who have already been diagnosed with heart failure. That one's kind of on, people are on the fence about that. There are drugs that are used, there are people who treat heart failure that use beta blockers, and there's some good reason around that, but that's something to sort of think about. And people with heart block. Again, that's a blockade of the impulse from the atria to the ventricles. So I'm pretty sure that does it, you guys. We have completed the peripheral nervous system unit, which is arguably the most difficult unit we do. There's a lot of material. There's a lot in the cardiovascular unit, which we're going to do next. So again, remember to put the time in on the front end. Get that organization down. Get those neurotransmitters. Get the receptors. You got to have that before you get to the drugs. If you're super solid on that, the drugs should be easy. You should be able to use your common sense to know, just to use what you know about the setup and think about what would happen if you stimulate or block and why you may or may not want to use those drugs. So I will see you soon. Next on the agenda is the cardiovascular unit, which is also quite a long unit. So remember to set a little bit aside a little bit more time to get into that. All right, I'll see you whenever I see you.